All right, so we're going to take a look now in going out on a limb, the anatomy of the upper limb, at some more nerve injuries. In the previous lecture, we talked mostly about nerve injuries of the brachial plexus, those being Erb-Duchenne palsy and Klumpke palsy. Now we're going to turn our attention more to the nerves of the arm and the forearm. And here we're also going to take a look at one of the methods that's often used in medical education, that being case-based learning. So in each of these three examples that we'll see for the nerves of the arm and forearm, we'll be presented with a case, and we'll think critically about that case. What is the nerve that's being affected? What are the signs and symptoms that we would expect with this? And what are the muscles also that are being affected by that nerve lesion? So here's our first case. We have a 36-year-old man. It says that he has a recent ankle fracture, and now he's complaining of some numbness over his lateral shoulder and some difficulty raising the arm. And so we take a look at this case and we say, well, recent ankle fracture. That's a totally different limb. This isn't going out on a limb, the anatomy of the lower limb. We're looking at the upper limb here, so how does that connect in? And the connection here, or the clue that we're getting, really comes from this image over here. When somebody does have a significant ankle fracture, of course we may cast that patient, and we often will be giving them crutches. So consider what crutches do. They are certainly useful. They're going to still permit this person to have some mobility, but if somebody is using crutches incorrectly in particular, they may be putting undue pressure right into the axilla, right at that proximal portion of the upper limb. So the question here would be, what nerve is affected? What nerve will cause this numbness over the lateral shoulder and would also be involved in raising the arm, abduction of the arm? We'll also wonder why this is happening. As we said, it's primarily due to those crutches, but also what other muscles may be affected here. What would be the deficits that we would expect? So, of course, if we're talking about some of the skin over that lateral shoulder and abduction of the arm, the first nerve that should be coming to mind here is the axillary nerve. Remember, the axillary nerve really only innervates two muscles. It is one of those main 5 branches that come off the end of the brachial plexus, but the only two muscles that it innervates are going to be the teres minor, which is one of our major external rotators of the arm, although not the only one. Remember that while we have the teres minor here, we also have the infraspinatus helping with helping with external rotation. And we have the deltoid. Now the deltoid is our main abductor of the arm. Remember, the supraspinatus up here does again contribute for at least the first 15 degrees. The main reason for that being actually the deltoid, if you look at its orientation, can't really get good torque. When the arm is at 0 degrees, it can't really get that good rotational motion, whereas the supraspinatus, through its long tendon, is able to do so. But the deltoid is our powerhouse through most of the angle of that upper limb to allow for abduction, so we are going to have some weakness there. And also remember, the axillary nerve, its cutaneous distribution is primarily here in the lateral shoulder and upper arm. So this patient may complain of some tingling, some numbness, some unusual sensations in that particular portion of the upper limb. So axillary nerve injuries, remember, the primary way that this would occur is if we were to have a compression in the axilla itself. The axillary nerve, just to point it out here in the diagram, is coming out right here, and you can see it going to innervate that teres minor and going to innervate that deltoid. Here we're looking at the posterior aspect, but you could certainly imagine if we were more anterior, and if we were looking from the anterior edge, that a crutch going into the axilla could cause compression of that axillary nerve along the bony structures, along the humerus at its most proximal end. So that's one case. Let's take a look at another. In our second case here, we're going to take a look at a 56-year-old homeless man who says that he fell asleep last night. He was sitting on a park bench, and maybe even if he describes this to you, when describing that sitting on the park bench, he may say that his arm was sort of resting over the back of the bench. He had his arm resting on the wood of the back of the bench. And now he awakes, he may have some numbness and tingling in his hand, but the primary thing that he's complaining of is, I can't move my hand. When you do a little more examining, you find that really the problem here is he can't extend his wrist. That's the primary thing that we're noticing. What we may call in medicine a wrist drop, that this patient has a wrist that can be flexed but has difficulty extending that wrist, and may also have some difficulty with extending the fingers, primarily at that MCP joint for the fingers. So let's think about that. what nerve may be traveling in that area where it could have been compressed through that humeral mid-shaft area, and then goes ahead and extends the wrist, ends up innervating those nerves that extend the wrist. Well, the nerve for this, of course, is going to be the radial nerve. We're asking what nerve is affected, why this is happening again, what muscles here would be affected. We've got the radial nerve. The radial nerve, remember, is going to innervate the triceps. Now, the triceps is not primarily affected here, and the reason for that is where the compression is occurring. Remember, the radial nerve travels in the spiral groove of the humerus, and that's pretty much where it's getting compressed here, about mid-shaft in the humerus as it's wrapping around to eventually innervate posterior forearm muscles. The triceps itself, again, is innervated by the radial nerve, but the branches that ultimately feed the long lateral and medial heads of the triceps break off a little bit earlier than where this compression would be occurring. So this is giving us a good example of, again, a more proximal lesion may have affected the triceps, but a more distal lesion will have fewer signs and symptoms. We would expect it maybe not to be affecting the triceps in this case. It's a bit distal to the point where those nerves come off. So then again, the radial nerve, remember, is really the main player in the posterior forearm. It innervates all of those extensor muscles, the extensors of the wrist, and the extensors of the fingers at the MCP joints. And so for this particular patient, because we really don't have many contributions to the triceps distal to that spiral groove, they're not going to complain of any difficulty with extending at the elbow, but they'll complain of not being able to extend the hand. Of course, when somebody has a difficulty with extending the hand, they actually generally come in saying, I can't move my hand at all. Usually, if you do a little bit more examination, you'll find that actually they do generally have good flexion still, but it's again that extension of the wrist that is primarily affected here. Those posterior forearm muscles coming down to cause that extension of the wrist and the extension at the MCP joints. So the radial nerve does act at the shoulder, at the elbow, at the wrist. It does act on the thumb as well through the abductor pollicis longus and the fingers, again, at those MCP joints. But remember, primarily here for a radial nerve lesion that's occurring at the spiral groove, we're really looking more at these last few portions, primarily, again, the wrist and fingers that patients would complain about. Okay, so let's take a look then at our third lesion for today. And this is our third case, a 55-year-old woman who recently had surgery to remove breast cancer, and now she's complaining of some difficulty with combing her hair. So if we're talking breast cancer, we're thinking if we had maybe a total mastectomy to remove that breast cancer, then maybe some of the nerves that lie closer to the upper limb, that lie up in what we call the tail of Spence, the tail of Spence being essentially an elongation of the breast that goes up into the axilla, that maybe some of the nerves that lie near that tail of Spence may have been affected here. So we'll ask the same questions. What nerve is affected here? Why is this occurring? And again, what muscles are being affected? What other deficits may you see in a patient like this? We said, again, the big hint here is that total mastectomy that probably occurred when this patient had breast cancer being removed. And in fact, if they had a radical mastectomy where they had dissection of the lymph nodes that lie in the axilla, essentially removing any lymph nodes, trying to find any cancer that lies within those lymph nodes, then this may be a patient who had nerves in the axilla get affected. And here, if we're talking about difficulty combing the hair, we may ask the patient to give us a little bit more of a description of what the difficulty is here. And if we did that, generally the patient would say, primarily it's hard if I'm trying to get that arm up, and then also just to comb forward. I have difficulty with getting my arm to move forward to do that combing. So essentially the motion then they're describing, we have a little bit of abduction, we have a little bit, but primarily we've got that protraction of the scapula being affected. So remember, what muscle is our major protractor of the scapula, and what nerve innervates that muscle? Well, the nerve that we're talking about here is the long thoracic nerve, and that muscle is the serratus anterior. Remember, the serratus anterior attaches to the ribs, primarily ribs 2 through 9, and it's going to attach to the anterior aspect of the medial scapula. In so doing, when the serratus anterior starts to contract and pull forward, we're going to end up with that scapula getting protracted. So here, if the patient has weakness of the serratus anterior because of loss of function of the long thoracic nerve, then we could see difficulty with protracting that scapula. Now, the long thoracic nerve itself does not come off in the brachial plexus. It's actually even a little bit before that. It's made up of the innervation of C5, 6, and 7, actually right as they're coming out of the neck, right as they're coming out of the cervical spinal cord segments. So actually the long thoracic nerve, while it is going to be acting on muscles that do act on the upper limb, actually does come off from the innervation here a little more proximally than all the intermingling that we see within the brachial plexus. On exam, if somebody had an injury to the long thoracic nerve, one of the ways we may test for this is ask them to support some weight on a wall. We may have them standing with a wall in front of them, ask them to place their hands on that wall, and to essentially allow themselves to rock forward, trying to keep their body stable, to essentially do a push-up on the wall. And when we do that, we may see some winging of the scapula. A winged scapula will occur when we have a posteriorly directed force acting on that scapula, causing some forced retraction. Here, if the patient does not have the protractor active, if they can't contract that serratus anterior, then they have difficulty maintaining stability of the scapula on the posterior chest wall, and it begins to ride actually off of the posterior chest wall in, again, forced retraction. So you can see this effect here, this winging of the scapula. The patient's shoulder here, they're in a slightly different position, but is showing a similar effect. The shoulder blade itself is beginning to stick out from the skin of the back, mainly because it is in forced retraction, and it's having difficulty being held in place because the serratus anterior, our main protractor, is having difficulty contracting with that long thoracic nerve injury. So that brings us to the end of our second lecture on nerve injuries. In the next one, we're going to start taking a look at the hand itself, nerves that innervate the muscles of the hand, and some of the classic signs and symptoms that you may see in hand nerve lesions.